I'd like to introduce Dr. Haruhiro Inoue. He is a world-renowned surgeon and endoscopist. He's a professor at the Showa University School of Medicine and chairman of the Digestive Disease Center at Showa University Koto Toyosu Hospital in Tokyo, Japan. Dr. Inoue, has also been the chair of the Showa University International Training Center for Endoscopy and Surgical Endoscopy. And he is a pioneer in many endoscopic therapies. He's done a lot of EMR, including CAP EMR. He did one of the, developed circumferential EMR for Barrett's esophagus with hydroid dysplasia, and had the first clinical report of anti-reflux mucosectomy. He's also did the first case in the world of POEM, which we're, of course, all very interested in, and has also done endoscopic resection of submucosal tumors using a POEM-based platform. He's been a long-term member of the ISDE, and we're thrilled to have him talking with us today.
So, Dr. Kerry, thank you very much for your kind introduction for me, and the Dr. Jan Tack. I also appreciate it. So I would like to share my slide. Hopefully you can see it. So can you see my slide? Hello. Hello.
Yes, we do see the slide.
Oh, okay. So this is my COI. And the Dr. Kerry Dunbar talked already the PPI and the if it's not effective, so we perform a conventional surgery and Nissen fundoplication to pay. So we want to fill the gap between the medication and the surgery. So everybody knows Nissen, Rudolf Nissen. So he's a pioneer of the Nissen fundoplication. And in his technique, crural closure and the lap, circumferential lap of the abdominal esophagus, that is our anti-reflux barrier. So this is a laparoscopic surgery, Nissen fundoplication. Operator is myself. So now we fix the lap to the abdominal esophagus. So to pay fundoplication, we place a 270-degree posterior fundoplication like this. So I have a very unique experience. So that happened 2002. So this may be the first case of an anti-reflux mucosectomy. Okay. So this patient is the age of 60s, the 20 years history of GERD, the CAP in the midnight and the free reflux or severe reflux condition. Actually, patient had the Barrett esophagus short segment, and we took 7 biopsies from this patient esophagus Barrett's, and then all of them demonstrated high-grade dysplasia. So, but it looks mucosal, still intramucosal cancer. So we try to resect the whole mucosa out. Anyway, so in a retroflex view from the stomach, we can recognize the hiatal hernia. So anyway, in this case, we resect the whole distal esophageal mucosa, and the at the time, so we also perform a mucosal resection in a gastric caldea, circumferentially, 2 centimeters from the esophagogastric junction. So surprisingly, 6 months after this procedure, the patient's junction became tight. So patients satisfied very much with the improvement of the reflux symptom, and the pH and the bile reflux also controlled within a normal range. So we reported this case to the Journal of Endoscopy 2004, 16 years ago. Anyway, we followed this patient 12 years. And surprisingly, junction was still tight, and the distal esophageal mucosa was whole replaced with the healthy squamous epithelium. So right-hand side bottom, you can see iodine staining squamous epithelium, no recurrence of Barrett's. So then we think that we can independently apply this mucosectomy to control the reflux disease. So that is, so first we apply the mucosectomy, but after that we realize the anti-reflux mucosal ablation, that's enough to make the junction tight. You can see two case threes. Top four images are the left to right, the clinical course. Before anti-reflux mucosal ablation, the junction is open in a retroflex view. And we place the nearly circumferential mucosal ablation on the gastric cardia mucosa. And the light, you can see the 1 month after procedure, junction became tight. So bottom, fourth slide is another case, open hiatus before procedure. We place circumferential, nearly circumferential ablation, and the 1 month after procedure, junction became tight morphologically. So another case, so this is an observational study in this patient, but anyway, so before treatment, open hiatus, and then after armor, so junction became tight, and the symptom score, F scale under GERD, HR, QL improved dramatically, and stopped DPI. So we reported initial experience to Journal of Endoscopic International Open. So this is another case. So before treatment, left two slides, top and bottom. So before procedure, junction is open like this, but no sliding hernia in this case, just open hiatus. Anyway, so we place the ablation in the center slide, nearly circumference, and then 1 month after procedure. So because of the healing process of the mucosal ulceration, the junction became tight, and the symptom score improved, and the some pH study improved. So this is a summary of our technical tips of armor procedure. So we place a nearly circumferential ablation at the gastric cardia. So yellow arrow demonstrate we have to preserve the 1 centimeter untouched mucosa in a greater curve side of the hiatus. And the green line demonstrate do not approach to esophagogastric junction. If we ablate esophagogastric junction, the patient become the temporary stenosis. So in order to avoid it, we have to keep distance from the endoscopy shaft. So 1 centimeter is ideal. And the blue line demonstrate the width of ablation. We have to place 1.5 scope diameter. Scope diameter is 1 centimeter, so 1.5 centimeter, or I recommend 2 centimeter. So this is a clinical data. The case number is 32. So before and after procedure, the symptom score improved. And the pH study, the acid exposure time, the composite score improved. So indication of anti-reflux mucosal ablation armor is this is a point. So open hiatus, horizontal widening of the hiatus is a good candidate for endoscopic ablation. But vertical deviation of the esophagogastric junction toward the mediastinum, it's we have to treat it surgically. If the vertical deviation is more than 3 centimeters, we have to perform the laparoscopic Nissen or Toupet fundoplication. So this is the left to right. So Nissen fundoplication is our strongest fundoplication, and the Toupet is the 270. And then the next is the arms and the armor procedure. So junction becomes tight mechanically. And the DOE fundoplication is a weak fundoplication because we apply DOE fundoplication after heramyotomy. So achalasia patient has no peristalsis of the esophagus, no clearance of the esophagus. So POEF is I talk it later. Okay. So next, I'd like to talk the oral endoscopic fundoplication briefly. How can we avoid a postpartum GERD? That is a question. This is the success rate of effectiveness of the POEM procedure for esophageal achalasia. 90 to 100%, most of the big institute, and the so postpartum GERD occur 20 to 50%, and the 0 to 3% patient have to receive the additional anti-reflux surgery after POEM. That is a potential problem of the POEM. In order to control it, we recommend double scope method during POEM procedure. So this is the actual video clip. So pediatric scope is in the stomach and keep lateral flex, and the submucosal endoscopy goes in the submucosal space. We can see a light of the submucosal endoscope by the pediatric scope in the stomach. So then we can control the gastric myotomy lengths. So ideally 1 to 2 centimeter is a best dissection length of the gastric side. So Dr. Kevin Grimes conducted the RCT, and the, in his report, gastric myotomy length more than 3 centimeters results in increased rate of moderate and severe esophagitis. So this is a guideline in the Japanese society. So we recommend that we strongly recommend that the gastric myotomy length during POEM procedure control to 1 to 2 centimeters. So next, I'd like to talk about the oral endoscopic fundoplication briefly. So this is a surgery, heramyotomy. We place the DOE fundoplication. So, same thing, we do endoscopically. So getting abdominal cavity through the anterior submucosal tunnel, and then make a fundoplication. So first case was done in 2017. One of my colleagues reported. So far, we perform 45 cases. Actual procedure is like this. Okay. So first introduce the loop and the clip technique. So before POEM, achalasia patient has a tight junction. And then after POEM, of course, we dissected the LES totally, then hiatus is open like this. So in this case, we place the anterior submucosal tunnel and then approach to a peritoneum. Muscle dissected using flexible endoscope. Behind at the front, we can see a back side of the left liver lobe. And then getting an abdominal cavity or CO2 insufflation. So this is a surface of the anterior stomach. We place a distal anchor fix the snare, fix the loop with a clip. We place a second clip, and this is a proximal anchor ring. So we place a clip onto the abdominal esophageal wall. And then after this, so we place 2 or 3 clips. No, 3 or 4 clips. Then we close the end loop. We can make anterior fundoplication. This is an actual video clip. We close the end loop in a submucosal tunnel. And then, so please watch carefully, the right side, the fold is coming over open hiatus. So this is the before, after myotomy, before POEF. And the right-hand side is the after fundoplication. This endoscopy image is very similar to after jaw fundoplication, surgical jaw fundoplication. So next, I'd like to talk about the using of the suture material. We use a V-lock. So approach is the same way, approach to the anterior wall of the stomach, the place the V-lock suture, and normally we place 2 sutures. And so this is the actual procedure. Once again, we approach anterior wall of the esophagus, create a submucosal tunnel, and the distal end, we approach to a peritoneal cavity. The front, you can see the surface of the liver. We open up the peritoneum enough to pass the endoscope to the abdominal cavity. Then, so now we place a suture onto the gastric anterior wall, full thickness of suture. We can place it endoscopic, pure endoscopic procedure. This is a pure notes, no laparoscopy assistance. So this is monitoring in an intragastric scope. Needle is coming into the gastric cavity and then out. So this is the proximal anchor. Now we place a suture onto the light crus muscle layer in a submucosal tunnel. Then we can make a fundoplication like this. So technical success rate is 100%. pH impedance monitoring demonstrate the better results than a poema alone group. So this is my conclusion, right? So anti-reflux procedure, arms armor is a middle effect, and the POEF is weak, but in the case of achalasia, it works. So thank you very much for your kind attention.
Thank you for explaining all that. It's very fascinating to see all these kind of new developments in GERD. We in management of GERD, we have a question in the Q&A box, and if anyone else has them, please enter them there. You described ARMA for patients with an open hiatus, but that's a small portion of our patients with reflux. What proportion of your reflux patients do you think you can use ARMA to treat?
So best indication, thank you very much for the nice question. So best indication of the ARMA procedure is the nerve patient, the patient who has a reflux, not major, minor reflux. So, but the anyway, so no deviation of the junction toward the mediastinum. In such a case, is the best thing. So I'm not sure what percentage, but maybe half. I think half of the GERD patient is the candidate, particularly NERD patient, not the GERD patient.
Kerry, any more questions for Dr. Inoue?
So I don't see anything else in the chat. for the one where you're ablating below the GE junction, do patients have a lot of discomfort afterwards, or are they back to, what do you have to do? So that's one of my questions. And then as far as like diet and management for these patients after the procedure, what are you guys doing?
So thank you very much. Maybe we can do it in an outpatient basis, but in Japan, the insurance system is totally different. Staying in the hospital longer, so no charge to the patient. So less charge to the patient. So patient want to stay hospital. So most of the patients stay 1 or 2 nights to the hospital. So some patients feel so uncomfortableness, unpleasant feeling at the epigastric area. So 1 day, 2 day, but of course we prescribe PPI, then we can control it. A few days complain.
That's
if
not
I
bad.
may, I would like to ask a small question as well. For the anti-reflux mucosal ablation, the apposition, I think, is a fibrotic procedure. So has it ever caused dysphagia necessitating dilation, or has this been exceptional or not even seen?
Thank you very much. That is a very, very important question. And in our pilot study and in our initial series, we ablate the close to junction, esophagogastric junction. Then the patient became a temporary stenosis. Usually 1 or 2 times balloon dilation, regular balloon dilation, 20 millimeter balloon, that works well. But so like current method, we keep some remnant mucosa, untouched mucosa in between the shaft and the ablated area. Then so we have almost zero, not zero, but almost 0% of temporary stenosis. Welcome.
Thank you. I think that concludes this part of the presentations, and then I think we go to our usual strongest, sometimes last resort, which is surgery.